Hey everyone, Dr. Z. Welcome to the ZDoggMD show. Today's guest is Dr. Eran Bendavid. He is a colleague of mine from Stanford. Eran, introduce yourself, man. What's your deal?
Oh, thank you for having me. ZDog or Zubin? How do you?
You know what? How about fellow bald guy?
Fellow bald.
They're not going to be able to tell us apart.
No, we're totally. I'm the one with the glasses.
Yeah, that's true. That's true.
And so thank you for having me. Just to sort of introduce myself, I'm a professor at Stanford, and my background, I'm in the medical school. My clinical background is I trained in infectious diseases, and then did my research training in health policy. And I've been sort of in this border between infectious diseases and health policy, especially with applications to the developing world, and have been doing a lot of research that looks at what are the effects of our policies on population health.
Right. And what's interesting about your background is that's what drew you into COVID when this thing started happening, and you are one of the co-authors of the now legendary Santa Clara seroprevalence study, as well as the LA seroprevalence study, and a colleague of Jay Bhattacharya who was on the show the other day. So it's great to have you on as yet another voice and perspective to talk about. Now, how did you get into, It's crazy because you were living this very nice academic life and attending on the wards every so often and doing your research, particularly in the developing world, which, as you mentioned, so whether it's HIV, tuberculosis, malaria, figuring out how our policies affect the developing world has been a passion of yours, right? How did that translate into COVID?
So that's exactly right. And so, one of the perspectives that I've been sort of working with and trying to promote for a long time is the fact that our policies, whether we, think they're a great idea or not, they have impact on population health. And so I've worked on things that you look at what kind of when we talk about funding foreign aid for HIV, what kind of impact that has when we have these policies that try to promote abstinence or condoms, what kind of impact that has on actual health behaviors. And I've been sort of on both the parts that look at things that you would think are very political and things that are not. And so I've looked at things like the Mexico City policy, which is an abortion policy. It's a U.S. policy that prevents funding for any reproductive health or family planning organization that promotes abortion. Now, when you stop funding for these kinds of things, you also stop funding for other family planning services, and so we've looked at the impacts of that in developing countries that rely on U.S. funding for. So I've been on sort of this interface between policies and health impacts for a long time.
And it's important to talk about that because you can have outcomes research, which is what you're doing. You can have scientific data, but ultimately that's filtered through the values of a culture or a population and then applied via the political process to actual policy. And that's where things now under COVID have gotten so crazy because it's all become this stew of conflict.
Exactly. So now I'll say that the current climate, the current scientific climate for conflict is terrible. I've been in some situations in some areas of inquiry that are can be considered a little controversial. That's nothing like what we're seeing today, and that's a real loss because we're missing out on some serious perspectives that get drowned out in some in a serious amount of sort of discontent and strife, and it's almost like we forgot that what we're trying to fight is a virus, and instead we've sort of turned into fighting each other, and that's really unfortunate.
Yeah, and you've been part of this group now, the Stanford cabal, and it was crazy because when I saw your original study come out, that had estimated what's the actual prevalence of this virus in early, what was it, March, April?
Yeah, exactly, late March. And the late March is when we attribute our, because we did the study in early April, but because antibodies take a few days to develop, so we measured antibodies to the virus that causes COVID, to SARS-CoV-2. And because we measured it in early April, it's really a reflection, in the antibodies take a few days, it's really a reflection of what Santa Clara County was like in late March.
Got it. So there's that delay of getting the antibodies to be produced. And so what you were saying then, I remember seeing this, is like it could be anywhere, and you gave a range of between 40 and 80 times more prevalent than we thought?
That's right. Now I should say, it sounds like a big difference, but in many ways, it was a very straightforward scientific question. And, we answered it with, it was just a singular measurement that we had done. And our answer was, so let me just tell you. So while we were doing our survey, we had about 100 or 150 staff that helped us run the survey in Santa Clara County. We asked them, what do you think is the prevalence of antibodies to COVID in our county? And the answers ranged from 0% to 75%. And there was this huge range. And I think part of what we were hoping to do when we did the study was reduce that uncertainty. And really, sort of help, because that was the question of the hour. Nobody knew how widespread it was. All we saw was just cases, and we didn't really know how many people have really gotten infected. And so, we said, okay, well, we can really help this, and that was the original intent. And so, we came down to somewhere between 1% and 3%
of the population was already infected
in Santa Clara County. So we reduced that range of 0 to 75 to a much narrower range. You can do a lot with that, the ratio that you mentioned of how many infections to how many cases, somewhere maybe as low as 20, maybe as high as 80, but somewhere in that range, right? That it gives you a sense of how widespread the infection was.
Now, at that time, why was that an important study to do? Remind us about that, because
that's right. So so everybody wanted to know how widespread the infection was, because people wanted to know, is there a chance that we are approaching herd immunity, or that something like that is happening? We'll talk about herd immunity, I hope, because again, it's one of these things that sort of become such a flashpoint. Totally
ow!
Right.
I touched the third rail of science. Something called herd immunity, which we've been talking about for decades, is now something you can't even talk about.
So people wanted to know that. People wanted to know, can you get tested with antibodies? Because they were saying, well, if a lot of us have antibodies, maybe we're immune. We can go back and can we say something about that? No, that we were not studying that, but people wanted to know that. It was very important to know what the fatality rate of the infection was, and again, that was entirely unknown. Everything that was published at the time was from cases or from models, and nobody really knew how widespread the infection was. And again, given the huge range of possibilities, that makes a huge range for the infection fatality rate.
And that makes sense. And because when Imperial College first put out its original model, they're using data inputs of assumptions without big ranges on them. And to narrow down what those actual inputs are changes the projections of deaths.
Entirely. Now, I can understand why some people wanted to use the models early on. We didn't have any better data.
Right.
But I think it's very important to know that these models are, by and large, they're often wrong by orders of magnitude about their projections, and so once we know what are the critical pieces of information we need, and once we know, once we can have a better handle on the data, we should go back and revisit, because the imperial models are there's no way that they were right. They projected They projected.
Interrupt for a second.
Yeah.
The Imperial College of London models were the ones that were the basis of our most aggressive responses.
That's exactly right. They published their big model on March 16th, and on March 19th, that's when California shut down. Everybody looked at this and said, we can't, 2.2 million deaths projected for the United States. That's unacceptable, and we have to shut down. And I should say, in their model, they also said, if you shut down, you're going to reduce that by a whole lot. I don't remember exactly how much. And so that's those models needed to be revisited. Let me tell you just a few examples of where some of the projections went completely off. Now, it's hard to say, well, we didn't have 2.2 million deaths in the United States. People will say, well, that's because we had early intervention. Well, Sweden didn't have lockdowns, and the models projected something around 100,000 deaths for Sweden by August. How many have happened? About 5,000.
Okay, let's. I want to dig into that a little bit, and we'll get back to the seroprevalence study, because these are conversations that, in sound bites on the media, just don't come through. It's like, well, Sweden is folly, or Sweden has the answer. Well, no, what's really going on? What's going on with the projections? Well, 100,000 deaths versus what actually happened, 5,000. Why the discrepancy in your mind?
So there are two things that if you look at the model for how do they get to 2.2 million deaths for the United States?
Right.
It's very simple. We have 300 million people in our country. They estimated that about 60% of the population will get infected. So it's about 200 million. And out of those, about 1% will die. Here you get to 2 million. That's all it is. It's that simple.
Simple math. Yeah.
And it's the same for Sweden, the same for England, the same for all these countries. Now, we have not had any place where the infection looked like it penetrated 60% of the population, in part because we might have things like T cells that protect us from infection, in part because people don't mix evenly. These models assume that I am at equal risk as the spouse of somebody infected in Queens. Okay,
right.
So someone infected in Queens, I'm the same risk as their spouse. That does not happen. Our population is much more sort of lumpy.
Yeah,
and so transmission doesn't happen in that kind of even way.
What about the data out of those slums in Mumbai that are saying 60, 70, 80%?
That's exactly that's exactly the kind of place where you say like that is exactly where people are crowded together.
Yeah.
The conditions are such that they will transmit one another. They don't have access to PPE, to face masks and other protective equipment. It's exactly the kind of context where you might see that.
Right. And so to this point, there is no one answer for these models. These populations are very different. There is no one herd immunity number. There is no one IFR. It very much depends, right? Or am I seeing that wrong?
Yeah. That's exactly right. And so if you look at the seroprevalence studies, there have now been about 100 done in different places. Some places are, under 1%. Some places are upwards of 40%. And, Mumbai is sort of the extreme high, upwards of 50%. But there's a huge range. A lot of it is, you'd think, well, New York was hard hit. Seroprevalence is high. Spain Spain is sort of an unusual example. But sort of the places that, the Gangelt in Germany, hard hit area, high seroprevalence. And so, you see that huge range. Now, why is it that some places got hard hit? Very high inoculum. I think you talked about that at some point. Very sort of relatively crowded, high density population. There can be different sort of scenarios and ways of understanding that. But you see that huge range. And I should say that also makes a difference for the fatality rate. The fatality rate is not a singular constant. It is a reflection of the population, how much comorbidities you have in the population, the age structure, the inoculum. Again, if you have a lot of people getting very severely infected, and of course the hospital capacity in the hospital system in the area.
So a couple things here. One is you study this for a living.
I do. And
you understand that there's a lot of, nuance and difficulty being black and white with these numbers because, like you said, it's a continuum. It depends on the location. There's multiple variables. It's kind of a Bayesian thing. Like, you have a little bit of stuff changing, and that changes everything downstream, right? You update your priors. You had this knowledge base. Now we learn more. Now you change your models. So that's one thing that I think is very important that has not been appreciated, I think, by the lay public as much, who want a black and white answer.
Yeah.
And the second thing that you said was Spain is a little complicated. Tell me a little more about Spain, because people are pointing to data now that, look, deaths are starting to rise in Spain, and maybe they're getting a second wave. And so how are you thinking about that?
I think you guys mentioned this in one of the previous shows, is that there hasn't been a true second wave in places that has already been severely affected. In the U.S., you sort of see this like shifting distribution. First, it was the Northeast, and then the sort of the West came on, and then the South, and now the Midwest is so. All of these you see this like shifting of the initial sort of pattern of disease penetration, and the same actually is happening in the UK and a lot of the places in Europe where you see a rise in infection. It's the places that didn't have a lot of cases and a lot of infections in the first time around.
Right.
And it's the same in Spain.
So these countries that we hold up as paragons of virtue, that did such a wonderful job, right? Like if you talk about, say, the Nordic countries, not Sweden, because Sweden is a pariah. But let's talk about the other Nordic countries, South Korea, Hong Kong, etc., New Zealand. They haven't had a ton of cases. They squashed it early on. Either they've had very aggressive shutdowns or they closed their borders and they're geographically isolated, whatever it is. In your mind, are they at bigger risk for this second?
Oh, they are. I mean, so this virus does have the ability to spread through populations, and so you can try to keep it off your borders for a while. It's going to make it through. You can try to sort of do a lot of very heavy contact tracing. That gets difficult and tiresome. In a lot of places, it's sort of those systems are fraying. Even the places that have managed to keep a lot of the sort of contact tracing and a lot of the early sort of quarantine methods in place for it's difficult. You keep your population in and out of quarantine, in and out of lockdowns, and that's what you have to do in order to prevent this virus from sort of spreading through the population. Now, is it worth it? That's a little bit of a societal decision, but it's a very hard question. My entire paradigm is that these are hard situations and hard questions, hard policy decisions. You're right. Let's not be black and white about these things. Let's take a holistic view of the costs and benefits, including, for a lot of places, the costs of really restricting population. You see what's happening in parts of Australia that are very locked down, and people are very they're miserable about this. And that's not an easy choice. And I don't think that that's something that we can just say, well, that it might prevent some COVID cases. But that's not the end of the story, and let's look at things in that broader lens.
So what? Okay, there's a lot, man. We're probably gonna end up talking for like 3 hours. What's the deal with Spain that you said they were so unique?
Oh, so Spain had a relatively low prevalence, and despite that, they seem to have a very high number of deaths. And so in that they're the ones. If anybody looks at the place where you might have had a high fatality rate, Spain is it. The distribution of a lot of it was, again, elderly. A lot of it was people with comorbidities, smokers. So those things were not unusual. But there's something about Spain where it looked like, relative to the size of the population, it seemed to have gotten infected. They had a relatively high number of deaths.
So could it be a mix of genetics, pre-existing T-cell immunity exposures, the way they live, smoking, pre-existing comorbidities, like we see in our, Latina population here? I refuse to say Latinx, by the way.
Okay.
I won't say it because my Mexican friends don't know what it is.
Latinx,
and I'm like, I'm not going to white-splain.
It doesn't flow off your tongue, right? It's really hard to say Latinx.
I'm not going to lie. I thought it was Latinx.
Latinx.
And because it just doesn't make sense when you read it. You're like, what is this? Yes. But so sorry. So the Hispanic population here maybe shares some of the care. I don't know. I don't think
this,
we do.
And this, that's a nice thing. We don't fully understand, and that's an okay place to be. We're going to try to understand more. We're going to dig into that more. We're going to do more studies into the T cell immunity or T cell features of the Spanish population. These things are going to happen, and we're going to learn more. But at this point, why is it that Spain is a little bit of an outlier? I don't know.
Yeah, and so I want to ask again about Sweden, because Sweden has become a political football in the U.S. And Anders Tegnell, there are accounts on Twitter that are pro and con Anders, and one of them is called Tegnell Stan. And a Stan, right? A Stan is a reference to the Eminem Stan, which we parodied, in fact, recently. And this is a big fanboy. He had a mea culpa and he was wrong. No, he's the comeback kid. What's going on with Sweden? How do we understand Sweden? And are there lessons anywhere for that?
So I'm going to give you a preview of a study that we're doing now.
Ooh.
So it's going to come out at some point soon.
Wait. I don't trust anything you do because it's all just terrible science, right?
Yes.
No. So tell me about the study. And then at some point, remind me, I want to ask you about some of the detailed criticism of your first study and how you respond to that, because I didn't get into that much with Jay.
Yeah, let's do that. Let's do that more.
So your new study.
I think we should come back, because I think the issue about the culture of science is very important.
Yes.
We need to have more civility and more openness in science right now to make progress. I mean, it is really critical, because right now we are embroiled again in sort of this bickering and animosity, and there's this process that I learned about in this book called "Mistakes Were Made but Not by Me." I don't know if you've ever read this book.
I've heard of that book. Yeah,
it's very good. It's called complementary schismogenesis, and no, it sounds big, but it's a very simple kind of concept that if you go left, I'm going to go right, and then because you went right, I'm going to go left, and because I went left, you're going to go right, and that's how the schism happens. That's the schismogenesis.
I see, the genesis of the schism.
The genesis of the schism, and that a little bit feels like that's what's happening, where people are just reacting to the position of somebody else instead of.
Open up your any social media account and watch what happens. If Trump says this, they say that. If Biden says this, they say that. It's predictable. And we'll talk about vaccines too. But that'll derail me. Right. But I got to say, this is a passion of mine. Is this schismogenesis that you're talking about?
Yes.
Yeah.
Anyways, I mean, it's why I like your show. I feel like you're peddling in moderation. And
that sounds so filthy.
I feel like it's so important.
I'm a middle peddler.
That's right. Yeah. Anyway, so I'll tell you about Sweden. I'll tell you a little bit about what we've done. And so, Sweden, made a choice early on, and the reasons for those choices, at least when you ask their public health officials, Tegnell and whatnot, is they said we want to contain the spread of the disease, but we want to make it in such a way that's going to be sustainable for our population. Okay, so that was the reasoning. And what they did is they banned gatherings, and they did some travel restrictions.
50 and above.
Yeah, exactly, right. And they made some policies that were mandatory, but a lot of it was about communicating to their people. Here's the disease. Here's the risk. Here's where it's spreading. Here are the people that seem to be most heavily affected, and let people make the decisions about what to do about that. And they had a relative serious increase in deaths early on. A lot of it was maybe 40-50% was in nursing home residents,
right?
And it spread very widely in nursing homes. It took them maybe 2-3 weeks to really more seriously curtail the spread of COVID in the nursing homes. And by that time, there was a lot of people who died.
Mortality high, yeah.
Mortality was quite high. And then the epidemic turned around, and their cases started going down, and their deaths started going down. For the past month, maybe even 2 months, their case number is sort of stable at maybe between 100, 200, 300 or so a day, and their deaths are 1, 2, 3, 4, 5 a day from COVID, and that's it. Now, I don't want to call this herd immunity, but to the extent that this is what a population where disease doesn't spread, that's how it behaves. As you don't see a growing number of cases, you don't see anything exponential, you don't see a spread and a worsening of the spread of the disease, and that's what's happening in Sweden right now.
They never overwhelmed their healthcare system.
They
right?
never overwhelmed their healthcare system.
Their population was generally adherent and compliant to whatever was recommended.
Yes.
If you look at Google Maps data and Apple search data, they were mobile. In other words, they went through a period where they auto-regulated. They said, you know what? This is scary. The population behaved as it probably should in the face of an unknown threat.
Right.
But then it opened back up, and you see it happen. And their deaths now are minuscule, whereas countries, let's contrast this with what's going on in Israel. They're talking about locking down again. You're Israeli.
Yes.
Yeah, tell me.
As of today, I think they went back into national lockdown.
So the only country to have done that.
So far, UK is talking about having some regional lockdowns now back in the areas, again, in the places, not the places that had the severe disease early on, but the places that actually got spared early on and now are seeing a resurgence in cases.
They were spared early on.
Yes.
Let's say that again. They were spared early on, meaning it's not a case like in New York or in parts of Spain where everybody's sick, it's very bad, and then they get better. And then it comes back very bad, and you have to we have not seen that happen.
No, we have not seen that happen. No, not yet. And I'm hoping. I'm not going to predict the future, but we don't know. The evidence on the lasting protectiveness of antibodies is still evolving, and
so Israel.
Yeah. Well, but let me just go back to Sweden. One more thing, because here's what we're doing in our study. Here's what we're looking at. We're trying to look at the effect of these highly restrictive policies of mandatory stay-at-home and business closures. Okay. Now, Sweden didn't do it. South Korea also didn't do it. Now, they had other measures, again, of trying to control the virus. We're looking at these two countries in particular because they were the disease certainly spread in the population. Okay, so you see the spread, and then you see a decline,
right,
in the spread, and so what you have there is you have some combination of the less restrictive policies and people's behavior and the natural dynamics of the epidemic, all sort of entangled, and so that's a nice sort of bundle that you can use to see what happens. Now, do you see the sort of the change in the pattern of epidemic? Do you see it different in Sweden compared to UK, Germany, Netherlands, the US, Spain, Italy? And the answer is, those are all countries that had much more restrictive lockdowns, had much more mandatory stay-at-home and business closures, and you see that there is no additional benefit that's left over from the mandatory stay-at-home and shelter-in-place policies after you look for what the patterns of both the sort of the behavior change and the epidemic dynamics and the less restrictive policies.
Okay, let me see if I can restate this
Yes.
and ask some questions, because this is such an important thing to discuss, and it's going to get all kinds of comments and criticism, and which is good.
Yes, that's good.
Which is what you want.
Exactly.
So you're saying that, and this is not published yet. This is a study you're doing.
Yes.
Right. That if you actually look, and what outcomes are you measuring?
We're looking at the growth in cases in the country, right?
Growth in PCR demonstrated cases.
Cases, exactly.
Got it.
Right. And we're looking at region by region within each country. So in the US, it's state by state.
Yeah.
In England, it's county by county. In France, it's a region by region.
And what you're proposing is, what you're seeing is that there is not an incremental benefit to having lockdowns on the number of increasing cases.
Exactly.
When you compare everything.
That's right. So we're we can see that there's a slowdown in the growth.
Yes.
Okay? This is sort of a complicated thing, but this is what Mike Levitt has been saying for
at
a long
Stanford.
time. At Stanford, he's been saying for a long time. He's saying, you don't see a real exponential growth. You see an exponential growth that sort of slows down, right? And so at first it's like 30%, and then it's 20%, and it's 10%. The growth of new cases day on day. And you see this sort of slowdown everywhere. You see it in the places that had lockdowns, and you see it in the places that didn't have lockdowns, and you see it in the places that implemented things early, and you see it in the places that implemented things late. And so the idea that the lockdowns are responsible for these slowing downs of cases is hard to make.
That is remarkable if true. And I got to say, I'll put on my skeptical hat and go, well, we're probably cherry picking data. We're not measuring it right. Something else is going on and more will come out. But let's say it's true. All right. What that tells me is something that I deeply suspect, and I suspected from kind of early on. If you don't squash the thing at the very early, like we did with SARS 1.
Exactly.
And SARS 1 was easy to squash relatively because
It's only hospitals.
And the fact that you were febrile and symptomatic when you were contagious. Now it's like, well, you're asymptomatic. I mean, you and me could be giving it to each other right now. We're not because we're awesome and bald.
That's right. Baldness protects people.
It really, was it the opposite? I read somewhere. Yeah, I know. Yeah. Well,
right.
Whatever.
How
being
about
male,
tall?
being
Maybe
bald. I'm screwed on all points.
Right.
But the thing is, if you don't do that, which is a human intervention, a top-down intervention, okay, we're going to squash this. Right? Once it's out and you have a virus like this, there is little to nothing in a top-down measure that is going to make a massive difference in the dynamics of the spread of this virus beyond the normal dynamics of the population's behavior.
I think that's right. I think people know it's coming. They're going to do whatever they need to do in order to try to prevent themselves or their kids or whatnot. So there's going to be some behavior change that's going to happen anyways because just because you hear it's coming, and then you have the natural dynamics of the virus, and the combination of these two things. That seems to have. Sort of contributed to a very similar pattern in all contexts, except for the places that you said, as you said, caught it when it was like 100 cases or something,
right? And
never let it really enter the population.
Never let the dynamics spin out of control from the early part.
Yes.
And okay, so that's, and remember now, you study this for a living. You're not a CNN pundit. You're not. You're not an armchair epidemiologist. This is what you do.
I have all I love digging my hands into the data and stirring them and looking
Nerd
into
stuff.
that and trying to understand and learn from the patterns. That's exactly what I do. Here's I would say that actually an important point about that. It's important to be able to learn and take the data in a personal kind of way, and that's not always easy because what we're seeing is a lot of very dramatic kinds of things about number of the cases growing here and big headlines in newspapers and whatnot, but we're not very good at looking at large patterns and saying, wow, that really matters. There is a famous study that some psychologists have done that looks at whether people care more about a single girl, as a single hungry girl in a picture, as opposed to 100 a news piece about 100 starving kids. And who would you give your money to? And people will give more money to the single person than to the 100 kids.
It's almost like you watch my show, but I don't think you saw yesterday's episode. You and I are both fans of Jonathan Haidt, and actually I'm a fan of Paul Bloom, who's another psychologist, and he's written a book called Against Empathy, and it's for that exact reason, that human beings empathize with singular stories. They cannot process mass suffering, they can't empathize with a statistic. That's why charities will always pitch you are going to sponsor Sharon in this country and get her a bag of rice, and we'll send you letters from her, because that makes you go, oh, yes, and I can empathize with Sharon. She's a single, but I cannot empathize with Somalia or a concept, right?
Right.
And when it comes to COVID, this has been very harmful to our rational ability to function.
I agree, and when it's individuals, you can understand that we're drawn to individual stories. But at the policy level, you want to be able to look at things in a more holistic and a more data-driven way.
I would say it's a more compassionate way, because compassion is more a cognitive empathy. Love and concern in the face of suffering, trying to help the most people as you can. Now, what's interesting is you'll see this as a pattern in my audience. My audience are nurturers and caregivers and nurses and doctors, and what they'll say, well, let's we'll leave the surgeons out of it. They're more psychopaths. But let's say we have a nurse. You'll see in the comments, but you guys are talking about, population dynamics and, this many lives and this many this. But I knew I had a patient who died alone on a ventilator who didn't have comorbidities. And we've got to do something about this. And that's how it feels.
Yes, and that's how it feels. And I fully and this disease has done terrible things to a lot of people, and a lot of people got sick, and a lot of people are suffering from it for a while still. All of that is true, and there are a lot of consequences to our actions. And so it's not a but, it's not a disregarding any of that. It's all of it. And I think that's an important aspect that we has not been part of the conversation much to date.
I agree, and we're going to dig more into that because I think it is so wrapped up. Like, for example, what you're talking about. I want to get back to Israel too because I want to see what's going on there. But I actually answer me Israel, and then we'll
okay,
and then we'll talk about what I think what you just said about the population dynamics and the fact that lockdowns may not have helped. How that will be politicized by both sides is worth discussing, and why, and how we can transcend that. So, what's going on with Israel, do you think? And I know you won't know, but
I don't know exactly, but this is again, Israel had actually pretty effective response in terms of the reduction of number of cases, and they went down to really pretty low levels. They opened schools, and then they had, they actually had one of the schools that had an outbreak of 100 or 200 cases in the school. That actually has been one of the early cases, and an example that people said, well,
shut all the schools down.
We need to shut all.
Now these are
cases.
Cases. These are not deaths.
No, not deaths. Not hospitalizations. Not a single one hospitalized.
Right.
Not a single one in that Israeli example was hospitalized. And then recently they've had a rise in the number of cases. Why that has led to sort of a decision to shut the country down again, I think is beyond me.
When I saw it, I'm gonna be honest with you. We can speak freely. I was like, they're making a mistake.
Yeah.
I don't understand why they're reacting this way, because this is the natural dynamics of a virus that was over-suppressed in the beginning and hasn't spread. You're going to see a case-demic as cases rise, not necessarily more mortality to the degree that the cases are rising.
Now, I don't know about all the detailed policies, but
Right.
I'll tell you one thing that's, again, we'll get into the politics. Maybe it's okay to get into a little bit of the politics over there. Is that for the past few weeks there have been these big demonstrations against the prime minister.
I see. Netanyahu.
Yeah.
He's been prime minister for my whole life.
I know he's been. I mean, he's been indicted. He's been, anyways, convicted of all sorts of things, and still is. I mean, it's sort of amazing.
Sounds familiar.
And I think there's been a desire to sort of make these demonstrations stop.
Right.
And it's possible that that there's that desire, the political desire to make those demonstrations stop is involved in the decision to make the lockdowns, because there are a lot of people who have been sort of advising the Israeli government, including Mike Levitt, who was there for a while. He was sort of stuck there in the beginning.
Nice Jewish boy.
And exactly, that's right. And advising the Israeli government and saying, there's no need for that, and yet at the same time, so.
But the stories of a person on a ventilator, or frontline healthcare professionals dying because they don't have PPE, and the heart moves, and you go, we have to do something. So now our policy should be interventional. Let's do something here. Forgetting that we have the empathy, we lack the compassion to look at the bigger impact. And what is that bigger impact?
Well, so let's talk about it. But I'll tell you, my wife's a psychiatrist, and
nice.
and so I'm gonna bring her in every once in a while.
So much. Oh yeah, please do.
Oh, she's great. And she says, one of the feelings that we fear the most, and that people have the hardest time dealing with, is the feeling of powerlessness. And so it's that feeling of maybe we can do something about that. And you're right that it's a new virus, and we don't quite know how to make those people those deaths sort of go down to zero, and we don't know how to make those cases. And again, and I think some of it is that those numbers are constantly in our face, right? Every day, every news story is like, number of cases, number of deaths, number of hospitalizations, and that's not that, and so you can't get away from the feeling of I got to do something about this.
Judd Brewer, who's a psychiatrist who specializes in mindfulness, was on my show a couple times in the early days of this pandemic, and we were both just outraged at the amount of fear being generated. And he said that he called it a social contagion. He goes, you could be safe in your house. Someone can sneeze on your brain from 1,000 miles away and panic you.
Yes.
And that's what's happening. And you know what? I noticed a pattern. The smart people I were talking to, the people who do this stuff for a living, were all like, man, why are people going ape? This is not, we're causing so much harm from the response.
Right.
And actually, we were going to do a parody of Nickelback's Photograph, where the media is putting graphs in your face every day and just be like, look at this COVID graph. Every time I do it makes me hack. What the hell am I doing here? But we never did it because
That's right.
It was locked down.
Okay.
But so your wife notices that and sees that powerlessness
is driving people to say we have to do stuff that and even if that stuff doesn't really have an effect.
I would take it a step further and say conspiracy theorists are trying to find control. So they're saying, you know what? I can't understand this. I need certainty. I need a way to explain this, something that's inexplicable. So something comes out of nowhere and potentially puts the world in a degree of peril where a lot of people are going to die. Well, that just doesn't happen. It must be Fauci created it in a lab because there's no other explanation.
Yeah.
But there are other explanations.
There are other explanations.
It's a failure
That's
of
right.
imagination.
That's
but
right.
Unfortunately, the truth is probably really boring and not satisfying.
And here's where my hope is that the harms of the lockdowns are going to become a ever bigger part of the story and of the general discussion.
Yeah.
Because so far they've been completely left out of it.
Now, when I talked with Jay about this, there were a couple commenters that were like, that's a typical straw man where you set it up and say, we're not talking about the harms of the lockdown, but we are, and that's a straw man. Okay. How do you respond to that?
So let me just say this. I would say that it is similar to the way that things like malaria in Africa is being addressed, where we know, if you looked at the reports from the WHO or whatnot, it's there. People are measuring it, but you don't get the same kind of thing. The parallel people would say, well, you should say that a 747 full of kids crashed every single day. That's what you get for COVID. That's not what you're getting for the harms of the lockdowns, and we very well may be having that. And so my hope is that those will be at least sort of on a level in the discussion.
It'd be a great way. This is brilliant, actually. I never thought of that. Imagine your main street in your town. Take 20 of them. Every day, that many businesses are going out of business that were mom and pop that lasted for 100 years.
I know.
And it's so heartbreaking, but they talk about it occasionally, maybe more on Fox News. It's like, it's so polarized. Like the left, they can't even mention it because it looks uncompassionate.
Yes.
That you're talking about money, but money is livelihoods,
So that's right. So let me talk about lockdowns a little bit. Okay. So if there are two findings in the social sciences that can fill a library each, it is that wealth is good for health.
Yes.
And education is good for health.
And both are true.
Both are true.
Longer lifespans, but yeah.
And I'm not talking about wealth like Bill Gates and Jeff Bezos.
No.
I'm talking about getting people out of extreme poverty of $1.90 a day per person. I'm talking about the progress we have made in sort of raising people out of extreme poverty. I'm talking about the fact that it is along the entire continuum of wealth that you're reducing child mortality. Everything improves when you're improving people's wealth. Okay, and that finding is like you can take the most sort of sophisticated data hack that cannot break away this pattern. More wealth, you live longer, you live better lives, you live, and you look at Raj Chetty, the very well-known economist. He's looked at every single American with their income tax return and their life expectancy, and it just goes. Just a straight line up. and it's a huge gap between the wealthy and the poor. Okay, so the fact that we're taking our GDP and really sledgehammering it, taking down by 5, 10, 15% in different places. That's going to have a huge impact, and that's so just saying like this is an economy thing. No, it's going to have a huge impact on health, on all sorts of things. Education, similar thing. This is not the kind of stuff where it's just like an association. People have done these randomized trials on Head Start, on people keeping kids in school and bringing them into high school, and you look at things like their risk behaviors and their well-being, and their especially for adolescent girls, their HIV risk behaviors, their fertility choices, teen pregnancies and teen births. Like randomized trials, not to mention all sorts of things about later life, sort of opportunities and risk patterns and the kinds of and violence and all sorts of things that improves with education. And what have we done? We've closed schools. Now, to say that closing schools is not going to have an impact on health, it's going to have a huge impact. And so, is it a straw man? Of course, people have been mentioning this, but it has not been on a level as on the discussion as COVID.
I mean, the little journey you just took me on, I was getting upset, like emotional. Like, we are screwing this up in a way that is so amazingly awful. Because we just can't see, our human brains don't function at the 30,000 foot compassion level. They function at the, oh my God, I'm scared. I need a sense of control. We need to do something, forgetting all the things you just said, which are all worsened by the fact that we politicized every single piece of this. And when you actually look at what's happening, if you say, okay, it's politicized on the right, it's a hoax, team denial. If you politicize it on the left, it's an apocalypse, team doom. The left in particular has completely forgotten that wealth equals health, and they will freak out about social justice while advocating the policy of lockdown and so on and closing schools that will worsen inequity for generations.
Yeah, that's right. And to the extent that inequity is hugely important for that entire for left for a lot of us, we don't want to live in this highly unequal society. I mean,
it's the biggest danger we have.
It's terrible, right? And
yeah.
I mean, we it's not good for anyone. It's we don't like it. Nobody likes to have this sort of constant sense of unfairness and inequity in this society. We don't want to live there. It's not the kind of people we want to be. And it's going to make things worse.
And you know what's interesting? So both Monica and Jay, who are probably on opposite ends of the political spectrum, see completely eye to eye on this. They're like, we're worsening inequity. What we're doing is we're penalizing poor people, and the Zoomocracy, the people who can live virtually, who are having a ball during lockdowns because it's like, this is great. I hate people. I can work and make money not doing in-person stuff, and I can just order an Uber Eats to come deliver me some food from an essential worker who's probably at high risk because they have diabetes and are sedentary. And honestly, if we looked inwards at it, we go, this is a policy failure. And the problem is, so if you're, let's say you're right, which I actually think you are, about this, and that our lockdowns are more harmful than they're helping.
UNICEF, by the way, they estimated how many kids, 500 million kids do not have access to school.
Because of this?
Because of this.
500 million?
Yes.
500 million children.
500 million children do not have access to school this year because schools are closed and they don't have access.
As of today, we stop doing this. You and me just decide, right? Just stop. Because what happens? You open the schools. Okay, people, this is a bad thing. We have a pandemic. It happens.
Yeah.
It's happened before. Our response is worse than the disease in some levels.
Yeah.
Not all levels. Like maybe distancing is a good idea.
Right.
Masking, Monica made a pretty compelling case.
Totally.
Yeah. So we could do that while still going on because so people push back all the time on the school thing. Well, there's all these cases in school. Yeah, they're not dying. Yeah, they're not hospitalized. What if they go home to grandma and kill her? Well, how do you respond to that?
I mean,
Or 40% of school employees are at risk for COVID due to comorbidities or age.
That is all right. And again, I think some of that is the decisions we have to make in a societal level. So strep throat has all sorts of consequences for kids. Causes them not only just the illness, but afterwards they can get kidney problems and joint problems and heart problems and skin, right? All sorts of things. We don't close schools to stop the transmission of strep throat, right? We make the choice that this is what's happening. On the one hand, these are our choices and our values as a society is on the other side, and we weigh one against the other. Now, this is again like where I would say science is a little bit paralyzed because of the polarization, because we need to know what are the risks of transmission. We need to know what are the risks for teachers. We need to know what are the risks of kids going home and having multiple generation kind of households and the exposures and the risks that would come from that. There is no hope for that right now in this environment, because these are all kinds of scientific questions that we can we can tackle and understand and put that into the broad discussion.
And this is what Vinay Prasad and I discussed on a previous show, which is that there are some things now that are so taboo you can't even study them. And Jay brought up Gabriela Gomez talking about herd immunity thresholds. No one will even review her papers.
Yep.
Because did you say herd immunity? Like that? Isn't that what like Trump's villainous Scott Atlas is telling him to do? And isn't that basically letting a disease rip through the community and kill everyone so that you can achieve immunity?
I mean, this is again talk about again strawmans and
you talk about strawmen, right?
This is herd immunity is a very simple concept, right? It's like when transmission, one person to the next person is when one person transmits it to one or less other people, right?
Yeah.
Then you achieve sort of the epidemic is going to extinguish,
right?
Then it's going to go down, right? Because it's not going to grow in the population. That's it.
Yeah.
That's the extent of it. It's not
nothing
political,
magical.
It's not magical.
Nothing political.
No, there's nothing political.
Now,
about that.
I think people rightfully say that if you have a vaccine, it's a preferred way to get immunity in a community because you won't have to suffer the infection.
I agree, right? But what's going to happen with the vaccine? I mean, again, like even the vaccine is becoming so politicized.
Tell me about this, because this is a mess.
It's a mess, and we I wish it wouldn't be this way, because if we get a good, safe, effective vaccine, I would want everybody to to get it, and
quickly.
That's quickly, and in this environment, it's not heading that way.
No way.
And I would say again, like there, everybody's politicized, everybody's sort of yelling at one another. I expect science to do better. And I expect the scientists to sort of rise above that and rise above the rancor and not get sort of entangled in this
Okay, so you expect these things, Eran Bendavid, and our own institution, Stanford University Medical Center, has created a letter that was signed by multiple people under probably pressure from former Dean Pizzo to speak out about Scott Atlas, who's former head of neuroradiology at Stanford, someone that my wife is familiar with, being a chest radiologist at Stanford, who works with the Trump administration now as in an advisory role and has taken actually stances compatible with what you and Jay are saying in terms of what the data is showing, but it's been spun through the political mill. And they felt compelled to write a letter saying, what did it say exactly?
So let me just sort of back out a little bit.
Yeah.
Stanford has, for whatever for reasons I think that are sort of understandable, has had several people that have taken somewhat non-mainstream positions between Jay, myself, John Ioannidis, Mike Levitt. These are all, and what I would say about all of them, maybe myself excluded, is that
They're awesome.
They're very prominent,
Right.
very known
Smart.
scientists, very smart. They're serious people, and Scott Atlas has been increasingly sort of involved. He's moved from the medical school to the Hoover Institution and has been very outspoken on policy issues. And he's been in the health policy world for a long time.
Right.
Okay.
Right.
But
he's not an epidemiologist.
He's not an epidemiologist.
Not an infectious
He's
disease
a neuroradiologist.
That's
He's been
right.
very interested in the interaction of the disease in the society and its impact, and has spoken out about it quite a bit. And
Right.
you're right, and including stuff that has become very politicized.
Right.
And even if my opinions align with Scott more than with many of the things he says, I am wary of the politics of it all.
Sure.
And so I don't want to get involved in that because I feel like again there's its own sort of separate dynamics. It's the schismogenesis.
Exactly right. Someone had asked me to comment on Scott's comments from a YouTube video well before all this happened, and I watched the video and I said, "Oh, so he's taking this tact. It does seem a little policy heavy, and he's got a definite bias here." And I don't feel strongly because I think it's just going to generate division right now. I've been talking about the nuance in this, but so go on. So
there have been a few people at Stanford. Now, why is it that this many people at Stanford? Well, Stanford, in some ways, its way of getting people through the door and promoting and rewarding people actually encourages this kind of independent ways of doing things. And so you have these people that are a little bit willing to not join a group or a tribe,
right?
And that's more so than in maybe in other institutions. Okay?
Interesting,
So
and maybe that's why I liked it so much.
And that's right. And so in that sort of soup of a growing number of people who are expressing opinions that are not of the sort of epidemiologic mainstream, you have a group of people signing a letter led by the former dean. Now, so the former dean, heads of divisions, heads of departments, all sort of signing and sending, asking people in their groups to also sign the letter. And the letter starts by saying, we uphold the principle of first do no harm. So it's a nice thing. I would say, I don't know what to make of that because as we said, lockdowns also do harm, and so in this very intermingled world of ours, it's virtually impossible to not do harm, given that we are in the middle of a pandemic. The pandemic is doing harm. The responses are doing harm. Let's think about them more holistically. And so the first do no harm, and then the second thing is they say that they are opposed to the falsehoods and scientific misconstruals, or I think
something along
these lines that Scott Atlas has been promoting.
Yeah.
Okay? So singling him out, as
they said, former colleague of ours,
right?
Not current colleague.
Yes,
right. Former colleague.
And so singling him out, putting him away, and saying that what he promotes are falsehoods.
Right.
And then saying what we believe is this. So they're not making the link direct, but they're saying what we believe are these 5 things. And I don't know if I'm going to get all 5 of them, but it's like masks are effective. Children get sick. Anyways, I forget. But
yes. And they were all, yes.
It's 5 things that are, that they say that is actually supported by the preponderance of evidence in the scientific literature.
That's right.
That's that. And I would say this, and simultaneously there's an op-ed in the LA Times written by 2 of the folks.
That's right.
Made national news and continues to sort of spiral in social media and it's going to creating more rancor within the university. There is a petition right away within the university to say that the use of this platform is something that is against sort of university principles. Having a former dean use the university listserv to send a letter out is against university principles because it suggests that this is a university endorsed policy. And so all of that is, is in my, it's a little my point of just like, that's not science. Science is not done by a petition. Science is not done by by sort of having who's more influential. Science is done by people coming together, sort of identifying questions, looking into them, trying to answer them, right? And instead, this is just further sends people into the opposite camps.
When I saw it and my wife sent it to me, I was just like beside myself. Like, why would my colleagues do this? This is not all the things you said. It's not science. This is grandstanding. It's virtue signaling. It's trying to control a narrative that isn't fully fleshed out or decided. And it also was misrepresenting whatever Scott is actually telling the president.
Right.
Because we don't know what that is.
No, we don't know what that is.
Exactly.
And certainly, things like, anything about, he's gotten under a lot of flack for promoting herd immunity. That is, I don't know everything he has ever said, but I certainly have not seen him. And I read the New York Times and the Washington Post. They did not quote anything that he has said that promotes herd immunity.
Right.
And so, I have not seen, that in the news. And so, again, like it's almost like irrespective of what Scott believes, this is, it's just a polarizing move. And again, like sort of here's the other thing that it creates an atmosphere within science that is not conducive to an open debate and open discussion.
Yeah.
At the very least at Stanford, where they know that there are, sort of a diversity of opinions about this.
Right.
I'm tenured, Jay's tenured, John Ioannidis is tenured, Mike Levitt is tenured, he's a Nobel Prize winner. What about a lot of the junior folks who might want to have, sort of a say in this and might want to, have their own opinions? This is bad for our diversity of opinion that we need, that is important for the progress of science.
Oh, it's so heartbreaking. It makes me so sad because the last bastion of discourse, of civil argument in our society are our universities, and we have turned them into you must fall in line. And what you said about associate professors that aren't tenured is so important. People don't realize, and I've talked to some people, there's a sense that they felt pressured to sign on to this document, because if they don't, the chair of the department or whoever who sent it to them saying, I think you should sign this, what are their chances of getting tenure or advancement or promotion?
If they do not.
No. And this is the opposite of what we want in our, and it's like Haidt and John Haidt has talked about this, that universities have become progressively more singular politically, and you're a pariah if you deviate from this. That is the opposite. And so what happens? The students are then trying to cancel speakers they disagree with instead of having them come and debating them. So without speech as our ability to argue, what are we left with?
No, I fully agree. I mean, here's where, I'll again sort of go back to some philosophers, but, it's attributed to Hegel, this whole notion of the dialectic, of, thesis, antithesis, synthesis. We put one thing, we put another, we come together in some kind of a way that moves us forward. And
you know what I'm seeing at Stanford? Hubris, ate, nemesis, Greek tragedy.
I know.
Arrogance, blindness, downfall.
Yeah,
that's what we're seeing.
Yeah, I will. So I'll go back a little bit to our study, because our study was certainly
pull me off the brink here.
It was sort of a canary in some ways of what was to come. And at various points we were very heavily involved in a process inside the university where they were, trying to different kinds of oversight about our study, and at some point they told us to pull the study from the they asked us to pull it, and they
actually asked you to pull the study.
They did. They said, take it off of the preprint server, stop talking to the media. We have those, and they came all the way from the top of the school.
Yeah.
At some point, there was a discussion about maybe we should, have more statisticians look at our findings. Okay, and so we wrote statisticians. We were the statisticians who have been most vocal in criticizing our work, and we said, let's get together, go through all our data, go through our methods. Let's go. And you can tell us what can be done different. What would you do that's going to be sort of a different approach to this? And their answer was, we're not interested in coming to the table. And I would say, I will make this call again to the statisticians, to other people in the medical school. Let's have an open discussion about these issues. A lot of them are issues that we can come together on. A lot of them, I bet there is a surprising amount that we can agree on. And we can identify the areas that, if there's disagreement, it's legitimate disagreement. We are all reasonable, sensible scientists, and we can identify those areas of disagreement and recognize what are the priorities. That's how we make progress.
Oh, and you know what? And we were talking about this before. The lockdowns have made all this worse because we can't see each other face to face. I couldn't shake your hand. We had to do this dumb elbow bump. Right? And, this is only the fourth or fifth in-person interview I've done. And I feel like I'm awake again.
Yeah.
I hate Zoom.
It's been one of these things that from early on in the lockdowns, I've been, where are the people saying I miss my friends, I miss my aunt, I miss my buddies, I miss my, right? We want to be with one another. We are the social animals, right? This is that it fills us with meaning. It gives us, right? I mean, I think to your point, part of the reason why we can't talk to one another is because Zoom actually prevents empathy.
Oh, 1,000%.
We don't see each other really. We don't have the same sense of, here's a good human being that I'm with, we're left with these almost like caricatures of one another.
Hollow caricatures. And Haidt said it at the end of the happiness hypothesis. He said, it's not about the meaning of life. It's not about the meaning. It's not about the meaning of life. It's about the meaning within life, which means between. So our interactions with our fellow humans give us meaning and purpose.
Entirely.
And it's been pulled away with good intent.
Yes.
These are good people making these decisions, trying to do the best they can under fear and incomplete information. But now we need to look clear-eyed at it and go, are the harms worse than the disease? And increasingly, and look, I went through a phase where I was very scared by those Imperial College numbers, and seeing that lockdowns actually seemed to really bend the curve, I said, now wait a minute, this could work. And now I'm more compelled even by masks and inoculum data. But that all being said, now looking at it as an emergent, looking at those patterns, telling you what you're telling me, what others very smart people are saying, I'm starting to say, I think my early instinct on this, which is that we have a hubris as a species that we're going to do something about this when it's already out of the bag.
I agree. I mean, we tend to attribute everything to the policies and whatnot. There is this. I think it was Daniel Kahneman in his book. He was like, what you see is all there is. And so you think that you see the policies, you see the cases. You can't help but trying to attribute one to the other. Well, if you start panning out, you realize that there are a lot of things that are unexplained. There are a lot of things that sort of go beyond the simple. Denmark did this and New Zealand did this, and look, they've won, and Taiwan and South Korea, well, they did the same, but they had a different outcome. In Sweden, they actually didn't lock down, but they now are having a good outcome. Right? There's a lot more than what meets the eye than from the what you see is all there is.
And I love that you cited Kahneman, because his whole point is, we as humans have very flawed, divided brains, system 1, system 2, and we make these snap heuristical judgments that are often, they served us in the wild in the day, but now things are complicated. And our second system that's slower and more deliberate often gets sabotaged because it requires a lot of ATP and time and wokeness to actually activate.
And I'll quote my wife again, who says, we all have the capacity to put our adult brains, our frontal lobe, engage them, and have a more deliberative process where we see each other for the goodness that we all bring, the good intentions, and and have that as a bring a slower, more deliberative, and a process that really sort of respects everybody.
I love that you quote your wife. I'll quote my wife where she says, "I still don't understand what you do all day." Different wives.
That's right.
Different wives.
If you want, when I meet her at the chest radiology, I'll let her know.
Oh, for sure. Yeah. Margaret will be there, I'm sure. But so to that point, I think we were talking before the show about Jonathan Haidt and his moral matrix theory, moral foundations theory, and the idea that everyone's trying to be good. They have different moral taste buds. And the right may weigh certain things differently than the left. And I've done videos about this relating to COVID. But what we should agree on is that we're all trying to be good. And like you said, it's going to be very hard. That little battle you're having on social media, on Twitter, where you're yelling at, Bob Harrington for whatever it is, whoever it is you're yelling at, like me and Jen Gunter have gotten it. It doesn't matter. If we were in the same room like we are right now, having this thing, there is no way we would vilify each other. We would hear each other out, disagree, argue, but it would be out of love.
Yes.
And that's what's missing in this piece of crap.
I fully agree.
Fully agree. And that's why now I don't like doing Zoom interviews anymore. It's got to be, I tell people, you want to be on my show, right? Well, then are you willing to come to San Carlos, California, physically be in a studio 6 feet apart from me? We'll do all the hygiene theater you want. But the truth is, that's how you have a conversation.
Yeah.
And if they say, hell no, then I go, well, let's wait till we can. Because at this point, except for Paul Offit, because Offit is so far away.
But you need him on.
And you got to have him on.
You got to have him show.
Isn't he?
Right.
He's
great.
He's the best. He's a rationalist. And, everybody falls into their politics sometimes, right? But it's just, he's such a reasonable guy. So let's see now, what didn't we talk about, Eran? Because we had a little tour de force and you got me real fired up.
I know.
I derailed the conversation multiple times.
Me too. I'm sorry.
But that's how it is. That's called human conversation.
That's right.
We could be like, okay, question. Tell me about vaccines. So do you have any other thoughts? We talked about the discourse. Do you have any other thoughts on the sort of variance in what you're seeing in infection fatality rates in the seroprevalence studies that you cite? Because Jay said on the show, he said, now multiple studies have borne out that maybe the IFR is somewhere in the 0.2 to 0.3% range. Is that being too narrow? Are we cherry picking data?
Well, so I don't. I'm not sure exactly where Jay. I know broadly where Jay got his information from, but I don't know exactly what he had in mind. But the most comprehensive analysis of seroprevalence studies, which is really the best way to get us to the fatality rate. Now, it's again not perfect, but it's much closer than case counts.
Right.
So the seroprevalence studies, the most comprehensive analysis of seroprevalence studies, was put together by John Ioannidis. He put together 86 of these studies, and there is a range. The median infection fatality rate across all of these studies is indeed 0.23.
That's the median.
That's the median.
So that's 0.23 of a percent overall fatality across all ages.
That's right.
Yeah. Mm-hmm.
Two out of 1,000. 23 out of 10,000.
Got it.
But there is a range, and it ranges from very close to 0%. In fact, the places that are close to 0% are some of the Central Asian countries, African countries, are the ones that have the lowest fatality rate.
Why?
It's very complicated.
Yeah.
I'll tell you that, especially the story with Africa, which is sort of, I certainly have a soft spot for that because a lot of my work has been on sub-Saharan Africa. It's mind-blowing. A lot of the projections for places like Uganda and Malawi, were somewhere in the order of 50,000, 60,000 deaths, something like that. We're talking about 40 deaths to date, maybe 100 deaths in Malawi. There's no hospital is reporting that there's any sort of meaningful number of COVID patients. On the other hand, number of kids that go unvaccinated is going up. Maternal mortality is going up. The World Health Organization has actually put out a recommendation to suspend mass vaccination campaigns.
I heard that for Gavi.
Not just through Gavi, just in general for everybody, to suspend mass vaccination campaigns in order to respect social distancing and to
madness. It's madness.
You think about the generation that's not going to get measles and not going to get DPT.
All these gains that are so hard fought. People have died to get vaccinations to the communities.
Now the expected vaccination rate that we're expecting for 2020 is the same as we had in 2000.
So 20 years lost.
20 years of gain, and with enormous gains in child mortality and reduction of childhood diseases.
With a benefit to us of net nothing, maybe, for COVID.
For Africa.
And so in Africa, these death rates are quite low. And could that be a similar scenario to what happens in the Mumbai slums, where there's something different in the genetics of the environment?
Exactly. So it's a combination of age structure, younger people, less obesity, less sort of the kind of chronic diseases that we see most closely associated with insulin resistance. Some kind of genetic differences, environmental differences. People will say, well, it's just that they're not being reported. That's a hard case to make as a meaningful.
Are so low.
The numbers are so low. No hospitals reporting. You'd expect to see them. In the big cities, people go to the hospitals in African countries. You don't see that.
What's happening in like Indonesia and places like that? I heard I haven't looked at the data specifically.
I don't.
Yeah, let's skip it because I don't know. Yeah. But it's something.
Vietnam has been a crazy story. Right?
What happened with Vietnam?
Vietnam had. For a long time they had. They actually also didn't impose lockdowns. It just never really seemed like the epidemic spread in the country.
Do you think that they've just seen these coronaviruses? Before?
It's possible. So that's another hypothesis that sort of is certainly. The story with T cells is still evolving.
Right.
We seem to have both T cells that react specifically after exposure, and we see that with the vaccination trials. They elicit a T cell response, and we also see that, people that have not had COVID exposure have T cell response that seems to be effective for COVID protective immunity. Now, to what extent that matters, it seems to be related to exposure to non-COVID coronaviruses, to other human coronaviruses, one of the other probably more common 4 circulating common cold coronavirus strains. The story remains to be, we're still learning a lot, but it certainly seems to be at least part of the story of why some people just are less. Don't get it as much, or don't get it as bad, right? The whole story that Monica was talking about, the inoculum, I think the T cell has a similar thing where it's not entirely going to protect you, but it's going to reduce the severity of the disease.
Just enough that you don't end up hospitalized or even that ill.
That's right.
Yeah.
But just to close the loop back on the fatality rate, so some places have a very low fatality rate, and then some places have upwards of 1% infection fatality rate. And it's the places where, that had really bad outbreaks that have the high fatality rate.
Right.
Italy, or northern Italy, New York, Spain. Those are the places that seem to have had a really high fatality rate. And basically, the fatality rate is not a singular number. It depends on the local context. It depends on the severity of the disease. It depends on the age distribution, on the comorbidities, on the health system. All of it. There's not a singular one sort of explanation that accounts for all of it, but in places that have had a confluence of these, risk factors, that that really has had a relatively, they have high fatality rate and they've had bad outbreaks. Places. We saw those pictures right early on in New York and in Bergamo. It was scary, and it was one of these things that really needs to be taken into account when we think about where are the places that are susceptible and how do we prevent this in the future.
And so to translate all that, it's complicated. We should study it.
Yes.
We need to look at both our response damage and the damage of the virus.
Yes.
We need to have open scientific discourse.
Yes.
We need to come at each other with love and compassion instead of fear and distrust.
Yes.
I strongly disagree with what Stanford did, and you don't have to comment on it, but I strongly disagree with that letter.
I agree with you that universities should be the places that uphold open debate and open speech, and this has been an act against that.
It furthers a momentum I see in academe of shutting down opposing discourse. And do you remember Peter Duesberg at Berkeley?
Oh, I remember.
You're an infectious
Certainly
disease.
in the HIV world.
That's right. So he was an HIV denier to the extent that he's a researcher at UC Berkeley where I trained. I actually saw a lecture with him in the early 90s, and he was charismatic and compelling. And what he was saying was HIV does not meet Koch's postulates, which are these postulates that say, okay, in order to show causation from a germ to a disease, you have to have these things. And HIV is not the cause of AIDS. Rather, it's behavior of gay men. It's this a very controversial, socially inflammatory stuff. But Berkeley said, you're a tenured professor. We can disagree with you. You're going to take a lot of heat, but go ahead and do your science.
And I would say even more though, so his ideas were out there. And there's so much compelling evidence against that.
Right.
That, by now, does anybody think that his theories are right?
No. So
And
eventually the science clears it up.
It does clear it up.
Exactly. And that's the beauty of it. But if you had shut him up, if you had said, shut up, Peter, you can't say that. You need to stop. We're going to close your lab, unpublish your preprint, do this. You know what? We, the people of UC Berkeley, hereby censure Peter Duesberg. What would have happened is it would have driven that stuff underground. It would have driven conspiracy thinking, which we already have. It would have radicalized people that weren't radicalized, and we're seeing that now.
Yeah,
people with good intention, trying to be good, put out this letter. You're actually causing more harm.
You see that now. I mean, there's that report that's now making the rounds of the potential human engineering of the coronavirus.
Right.
And it's like, it's fine. It's a report. It's very detailed. I don't know if it's true or not. I can't even evaluate that. But I think the fact that she's now being canceled, that Twitter is canceling her, it just fosters the like everybody's trying to sort of find it and
go reproduce it.
Go reproduce it. Go find other evidence. There's a lot of other evidence that suggests that it's potentially been natural.
Now you can always find a scientist to back some kooky claim that you have. You can always massage data, but there's always really smart people that can go and review it and be like, actually, not so much, and then do other tests, do other trials, and in the end. We're in a time where, again, we've been what was it? Schismogenesis? What did you call it?
That's right. Complementary schismogenesis.
Complementary schismogenesis has driven us to be irrational about a great many things. You and I are Kahneman worshipers. You can't worship anyone because that puts them on a pedestal where they can't be wrong.
Right.
You have to say, we admire that work. We're Kahneman knights. So we need to work on thinking about our thinking.
Yes.
And how we are in the world. And I don't know, man. Do you have any sort of, this is a personal question you don't have to answer, but do you have any spiritual practice or anything that you do that opens your sort of more compassionate center to being in the world?
Yeah. What do I say? I mean, I'm a pretty profound humanist.
Yeah.
And believe in that people have good intentions, and believe that people are, they're acting with good reasons and they want to be good.
Yep.
Let's me try to understand everybody.
You're a pinkerist.
Yes. I am a pinkerist.
Yeah, I'm a pinkerist too.
Yes.
And I add on a layer of meditative practice, a sort of secular Buddhism that allows me to understand the nature of my own mind, that then allows me to see when I'm being reactive and less wise in the world, less compassionate, less productive. So I think we could all use some practice.
Yes, absolutely.
Humanist practice, meditative practice. Even if you go to church and you want to have a prayer practice that's based on compassion, I mean, that's wonderful. We need a little more of that.
We could. And there's something where it feels like everybody could use a little bit of calming down, just a little bit.
Maybe
it'd be
like
so nice.
Little aerosolized Valium. I'm not much of a reductionist, but I do like that idea. Everybody then we'd all have the withdrawal and the benzodependence.
That's right.
So no good deed goes unpunished.
I know. Things are complicated.
The cure is worse than the disease, man. Eran Bendavid, this has been a joy.
Oh, thank you very much.
This is really fun. I'm glad we got to dig into those things and get riled up. And we'll put this out. I'll tell these guys right now, we're going to put this out on the podcast. There'll be a transcript. It's on YouTube and ZDoggMD.com, where ultimately the transcript will live. The transcript often has a bunch of errors in it because the people who transcribe right now, it's tough to follow us because we're crazy. And but give us a break. Do me a favor, share the show. Be kind to each other. Share ideas. In academics, we should challenge each other without censoring each other. We should come together as a tribe that cares about advancing knowledge. That's the kind of people I want to have on my show. I'm sure I pissed off everyone at Stanford. That's fine with me because you know what? It means if they come in here and they want to talk to me, that means we can find the love right here. All right, guys, I love you, and we are out. Peace.